Vitiello. And Dr. Vitiello is Chief of Child and Adolescent Treatment and Preventive Intervention Research Branch of the National Institute of Mental Health, and he's been in that position since 1997. He's a psychiatrist with expertise in psychopharmacology and treatment research. And today he's going to be speaking to us on adolescents and antidepressants, what is myth and what is reality. And during the talk, we'll be passing out cards, so if anyone has questions, be sure to write them down, and we'll collect those, and then we'll have an opportunity for question and answer session at the end. So join me now in welcoming Dr. Vitiello.
Thank you for inviting me and for the kind introduction. I know that the theme of the conference is depression in college campuses. So adolescent depression has some relevance. I think it has actually quite a bit of relevance because a lot of adolescents who suffer from depression then become college students who also suffer from depression. So this is important to address. As to what is myth and what is reality, of course, I will not be able to tell you with certainty, but I can certainly show you some data and to make some consideration that I hope may be helpful. When we talk about antidepressants, we talked about a fairly large and heterogeneous group of medications that are prescribed for the treatment of depression, but also for other disorders, such as anxiety disorders. And this group of drugs, even though it is heterogeneous, has all in common that acts through neurotransmitters, in particular serotonin, noradrenaline, and dopamine that are present in the body and in particular in the brain. There are basically two broad categories of antidepressants. The old antidepressants, we call them, or classic antidepressants, that were introduced and discovered in the 60s, and then the new antidepressants that were introduced in the late 80s, and fluoxetine or Prozac is the prototype of that group. Now, the new antidepressants are not more effective than the old antidepressants, are just more easily tolerated. They have fewer and less bothersome side effects, and they are also safer in overdose. The old antidepressants are fairly dangerous in overdose, and they're not very user-friendly for people who are at risk of suicide, like people with depression. So that's why the new antidepressants have become more and more fashionable, and basically they've taken over a large part of the market. For depression, these drugs are used to treat depression. So they're not mood enhancer, meaning they don't elevate the mood of a person who does not have a depression. So that's important to consider, except that if a person has a tendency toward mania or to become a bipolar patient, a manic depressive patient, this drug can switch the mood and from depressed just bring it to another abnormal state, which is the manic state. For depression, we mean something that is not just sadness, is not just moodiness, but a pervasive feeling of sadness, emptiness, and irritability that are quite abnormal, persistent in time, and causing significant distress or impairment in functioning. All across the day, I think you have heard about depression, and certainly you are convinced, if you were not convinced before, that depression it's a very insidious type of condition. It's common, and the fact that it's common and somewhat is in continuity with normal mood, it doesn't have a totally, completely qualitative, abnormal element, depression. It's not like schizophrenia where there are hallucinations or delusions that make the person quite distinct, let's say, from normal state. The depressed person has a lot of features that a normal person can also have, and make the insidiousness of a condition even worse. It's certainly impairing, has different manifestations. One can have impaired sleep or excessive sleep. One can have decreased appetite and weight loss. One can have increased appetite and weight gain. It also tends to improve with time. So it has, the episode of depression has a good prognosis. People tend to get better with time unless they commit suicide, of course, which is a rare event, but still a distinct possibility. Even if depression improves with time, it also recurs quite often. Basically, it has been determined that about 70 or 80% of adolescents with depression, when they recover, eventually they have another episode in the next 5 years or so. And of course, it is potentially life-threatening. Major depression is not that common before puberty. It's about 1–2%. It's not uncommon either, but it's not as prevalent as it is in adulthood. After puberty, however, something happens that is not quite fully understood, and depression becomes much more prevalent, basically reaches the same rate as in adulthood. And it becomes also much more common, twice as common in girls than as it is in boys. Since depression is an episodic condition that tends to recur, by age 18, one can estimate that about 20% of subjects will have experienced at least one episode of depression. Now, there is no question that the use of antidepressants had been increasing in subjects under age 19, so basically teenagers. It was only 0.3% in '87, and now is about 1.8%. It has become somewhat stable around the year 2000, so there hasn't been really any significant increase after that as yet. Now, the controversy, there are several controversies that relate to antidepressants, but the current controversy that we are struggling with, at least in the area of adolescent psychiatry, is the question whether antidepressants can actually trigger suicidal behavior in adolescents. Of course, it's a very paradoxical and provocative hypothesis, because antidepressants are supposed to treat depression, and depression is linked to suicide, so antidepressants are supposed to decrease the risk for suicide. So to imply that the antidepressant can actually trigger suicidal behavior is sort of very serious allegation, of course, and besides its controversy. The other question that was raised in parallel was how effective really are antidepressants in treating adolescent depression. In analyses that were conducted on clinical studies to determine if there was a signal for increased risk for suicide, it became apparent that a number of studies had not been able to distinguish the antidepressant from a placebo. And a number of these studies had never been published. So the public became really quite concerned that these antidepressants really are not that effective medication and are potentially dangerous. Now, the chronology of events is the following, basically, that since the introduction of the new type of antidepressant in the late 80s, and for the next about 10, 12 years, there have been anecdotal reports from families that their child, given an antidepressant, had become suddenly suicidal, and in some cases actually had committed suicide, attempted or committed suicide. These were just anecdotal reports that are very difficult to interpret, because suicide and suicidal behavior are quite common. Let's say not completed suicide, but suicidal behavior is a feature anyway of depression. And so it's very difficult to disentangle if this was due to the underlying psychopathology or if it was due to the antidepressant. It's not that the adverse event we're talking about was liver failure, for instance, liver toxicity. It would have been much easier to disentangle because depression is not linked with, is not linked to liver failure, but it is linked with suicidal behavior. So these anecdotal reports couldn't really be interpreted in any meaningful way. However, about 2 years ago, a little less than 2 years ago, in the summer of 2003, the British regulatory agency that controls the marketing of drugs issued a warning against the use of SSRI. SSRI is an acronym for Selective Serotonin Reuptake Inhibitors. It basically is the new antidepressant category, Prozac, and all the drugs related to Prozac, like Zoloft, Celexa, Paxil, and so forth. And the FDA, which is the US regulatory agency, conducted an analysis, a complete analysis that took about 1 year to review all the available control studies in adolescents. For control study, I mean a study where subjects were well characterized as suffering from depression, and they are randomly assigned to receive either the antidepressant or a placebo for a period of usually 2 months. Now, this amounted basically to 24 clinical trials altogether on 9 different antidepressants, but all these antidepressants were sort of Prozac-like medications. And the total was about 4,400 subjects, of which 2,200 were randomized to the medication and 2,200 to the placebo. Now, no suicides occurred in this sample, and epidemiologically, you wouldn't expect probably any, even though it's very difficult to estimate how much a depressive episode increases the risk of suicide. It's a deficiency that we have in epidemiology. We know that in the general population, a suicide is a fairly rare event that occurs, let's say, in 10 in 100,000. So you wouldn't expect any in about 2,200. Anyway, even though no suicide occurred, there was more suicidality. And for suicidality, I will discuss more what it means, or it is defined, is suicidal thinking or suicidal behavior, like a suicidal attempt. And the rate, the prevalence of suicidality was 2% on the placebo group, cumulative, and 4% in the antidepressant group. So it was double. And based on that, the Food and Drug Administration issued a warning that all drugs now need to carry, and it is the highest possible warning that a drug can carry, which is called the black box. Black box that warns the patients and the clinician and anyone considering using the drug that an increased risk for suicidality has been detected in clinical trials. That does not mean that antidepressant can be shown to increase the risk of completed suicide. So we're using suicidality as a surrogate marker in some way for suicide. Suicidality can be a suicidal attempt, regardless of how mild it may be. It may be just to take 2 pills that will count as a suicidal attempt. It's defined as an act aimed at inflicted self-injury with intent to die. So there must be an attempt to inflict an injury, and there must be an intent to die. Also, within the category of suicidality, there are suicidal threats or persistent or recurrent suicidal ideation with thought about a method of committing suicide. We know that suicide and suicidality are linked, meaning if someone has attempted suicide, for instance, the risk for eventually completing suicide later on in the future are much greater. However, there are also some discrepancies. For instance, suicidal attempts are much more common among females subjects, adolescents and adults the same. And on the contrary, complete suicide is much more prevalent among men. And also there are also some ethnic differences that are quite important. So it's certainly a valid surrogate marker up to a certain point, but there are also some differences between suicidality and completed suicide. If, and it looks like the data shown by this review of the Food and Drug Administration indicates so, if antidepressant increase the risk for suicidality, what could be the mechanism through which this happens? We don't know for sure. There are two primary hypotheses that have been put forward. I can summarize them here. One has to do with the antidepressants we're dealing with that act through serotonin. The other has to do in general with treatment of depression. The first one hypothesis is that since serotonin is mobilized by this medication, is increased in the body. And we know that serotonin, in some cases, can induce restlessness, agitation, as some psychiatrists call it, negative behavioral activation. People who are depressed many times have low energy. Sometimes they have energy and they're agitated, so they're a different type of depression. But to have positive behavioral activation is a good thing. So the person becomes more able to function, get out of bed, perform tasks. But there's also a negative behavioral activation, restlessness, rumination, inability to quiet down, to have a restful night of sleep. And all this, of course, is negative and is linked with anxiety. It can be linked with impulsive behavior, and all this can act and combine together and lead to suicidal behavior. So this is quite a plausible hypothesis, even though it remains what it is now, meaning a hypothesis. And research is in progress to try to see if that's really the case. The other hypothesis has more to do with the fact that it has been known that when depression improves during treatment or even spontaneously, the energy level improves, so the person becomes more able to function, to move, but the cognitive part, so the physical part of depression seems to improve earlier than the cognitive part of depression. So the person is able to do more, but is still feeling hopeless and helpless, and so is more likely to do something in order to hurt himself or herself, acting on the negative depressive cognition that is still there. So it has been pointed out in textbooks of the 30s and 40s of psychiatry of almost a century ago that when depression tends to lift, that is a high-risk period for the patient, and the patient seems to improve but is at increased risk of hurting himself. So these are two alternative, but not mutually exclusive, actually, hypotheses to try to explain the possible link. It's quite interesting that all what I have told you basically is based on anecdotal reports on clinical trials, but the epidemiological studies that have looked at the possible link between use of antidepressant and completed suicide, not the surrogate marker at this point, not suicidality, but completed suicide, point actually to a different picture. Both these two groups of researchers, Olfson, published this report in the Archives of General Psychiatry in 2003, and Robert Gibbons from Chicago, also in the Archives of General Psychiatry in 2005, has looked at the rate of utilization of antidepressant in different communities in the United States. For instance, Gibbons have looked at all the counties in the 50 states in the United States and looked at the use, the consumption of different type of antidepressants over the years in the 90s. And so this is one variable. And the other variable is completed suicide. And this is available through Vital Statistics. Vital Statistics will tell you how many subjects, individuals, and which age and gender and ethnicity had died of suicide in a particular year in each county of the United States. And what they found basically is the greater the utilization of SSRI medication, which is the serotonin novel antidepressant, the lower is the rate of completed suicide. So the epidemiology seems to be discordant with what the clinical trials actually have pointed out, also because the outcome variable in this case is different. Here is completed suicide for epidemiology. For clinical trial is suicidality, if you wish, a surrogate marker. I have already mentioned that in parallel with these concerns, it has emerged that a number of studies, particularly funded by pharmaceutical companies, have failed to find a statistically significant difference in improvement of depression between the medication of SSRI, antidepressant, and placebo, and they were not published. And the public, in general, was outraged by this, rightly so, I think, because it has emerged that there is a publication bias that is not specific to mental health, is not specific to antidepressant, it occurs throughout medicine, but still it is problematic. So the question that was raised is, was the efficacy of SSRI overestimated in previous analysis? And indeed, these antidepressants are not that effective to begin with, or they're not effective at all, and may be harmful. It's also important to keep in mind what could be the alternative to antidepressant medication. We know that depression is a disabling condition, and treatment is a good thing. So depression should not be dismissed. So if we're not using antidepressant, what are the alternatives? And over the years, different types of psychotherapy have been developed that are manualized, so people pretty much follow a certain active ingredients that are part of these manuals. And one particular treatment is cognitive behavioral therapy that tries to correct the cognitive distortion that typically go with depression and tends to mobilize and to make the patients more active, and so that's the behavioral component, to get into behavioral that are appropriate and not dysfunctional. There is interpersonal therapy, which is an alternative based on a different model, and there's also supportive psychotherapy. Now, supportive psychotherapy is used usually as a control in clinical trials, but both CBT, cognitive behavioral therapy, and interpersonal therapy, has been shown to be significantly better at treating depression than supportive psychotherapy, both in adults and in adolescents. Actually, cognitive behavioral therapy is a very effective treatment for conditions such as obsessive-compulsive disorder. More effective, actually, than medication. Sertraline is a Prozac-like antidepressant that certainly is an effective treatment of obsessive-compulsive disorder. But cognitive behavioral therapy is more effective, and for that matter, the combination of the two is even better. This is the rate of success of completely treating, remission is completely treating obsessive-compulsive disorder in children and adolescents. These are data published by the group of John March at Duke University in JAMA in December 2004. But what about depression? This is about obsessive-compulsive disorder. I want to present to you some data from the Treatment for Adolescents with Depression study, or TadsTED. TadsTED is a study supported by federal government, by the National Institute on Mental Health, conducted at different sites, 13 sites across the United States, and coordinated again by John March at Duke University. And the purpose of this study was basically to compare what is the effectiveness of antidepressant medication, in this case Prozac, fluoxetine, cognitive behavioral psychotherapy, the combination of the two given together, or a good clinical management with support and with a pill placebo as a control for the treatment of adolescents with major depressive disorder. There are different stages in TADS. The first one is the acute treatment for 3 months, and then patients who respond to that receive further treatment to try to reach recovery, and then maintenance for further 18 weeks, and then a follow-up. The data that are available so far relate only for the first 3 months. This was a study done in outpatients, adolescents, age 12 through 17, with a diagnosis of major depressive disorder. Some patients who suffer from substance abuse, or they have autism or other pervasive developmental disorders, or they have signs of psychosis like delusions or mania, or they were actually suicidal, were not enrolled because the study was not really appropriate for them. They needed other treatments. Also, other reason for exclusion was a recent hospitalization or being a high risk for suicidal behavior. So we tried to screen out, as typically happens in clinical trials, subjects with high rate of risk for suicide. The cognitive behavioral therapy was what was thought the best available, putting together different manuals, the different components with a cognitive restructuring to address the distortions that typically are part of depression, to adapt that to adolescents, a behavioral activation component, and a family therapy component too. The medication was started fairly low at 10 milligrams per day, and then gradually raised to an average of about 35 milligrams a day. So the dose was moderate dose, not to trigger too many side effects. There were more females than males, which is typical of depression. The average age was about 14 and something, so these were teenagers. Primarily white, but very good representation also of African American and other minorities. Middle class sample by and large. This is a measure of dysfunction. The higher the score, the higher is the functioning, the level of functioning. Subjects who are not dysfunctional, meaning who are functioning well, have a score usually above 70. So 71 and above means functioning well, not having any significant impairment in the ability of functioning at home, in school, with peers, and so forth. So this sample was certainly quite moderate to severe impaired with level of functioning. The depression was measured in 2 different ways. One was a symptoms scores. All the symptoms of depression were put together in the Child Depression Rating Scale revised and added up to produce a total score. The higher the score, the more the depression. And the other component was a clinical global impression improvement score, which is an impression of the clinician, how much the subject has improved since entering the study. And since both these measures are filled out by the clinician, there was also another measure that was fully completed just by the adolescent, which is called the Reynolds Adolescent Depression Scale, which is basically a self-administered questionnaire where the subject rates different symptoms of depression. And again, the higher the score, the higher the severity of the depression. This is the main slide of a study that tells the whole story in some way. Patients were randomized at this point, so they have one chance in 4 to be randomized to one of these 4 different treatments, which was support with placebo, pill placebo, which was indistinguishable from a Prozac pill, or Prozac, or cognitive behavioral therapy, or a combination of the 2. Now, one need to point out something that is important from a clinical trial point of view. When you do clinical trial, we try to have an unbiased assessment of the efficacy or effectiveness of treatments. And in order to do that, we randomize the sample. Another important feature is that we try to remove any biases in the assessment of the patient. And one way of doing that is to do a blinding or masking, meaning not to let the patient or the clinician know which treatment the patient is receiving. Because if they know, they may be biased. You know, some people think that medication are terrible, so they go a low score, or they think the psychotherapy is good, so they give better score, or vice versa. However, when you do psychotherapy, you cannot fully mask the patient because the patient knows that they are receiving psychotherapy. So you are in a bind, basically. You need to compromise. So in this study, the compromise was the two conditions, fluoxetine, which is Prozac, and placebo, were fully blinded because neither the patient nor the clinician knew if a subject was receiving fluoxetine or placebo, because these were just indistinguishable pills. And this is called double-blind. However, in these two conditions, the patient knew that we were receiving cognitive behavioral therapy, and in this case, they knew they were receiving cognitive behavioral therapy plus the Prozac. So there was no attempt to mask that Prozac that was received here. However, the clinician was kept blind, meaning that the independent evaluator who filled out the primary outcome ratings was not told which one the patient was receiving, meaning the independent evaluator was different from the treating clinician. So we call this condition single blind, but we cannot exclude that there is some bias here due to the fact that the patient knew what they were receiving. Anyway, back to the slide. Here you have time and three main points: baseline before treatment, 6 weeks, and 12 weeks. And here you have a rating of severity of depression. The higher the score, the higher the severity of depression. This line here tells you what it means not to have depression, which means to have a score of 28. This arrow here indicates what they were required to have in order to be admitted into the study. They needed to have some documentation that they have depression, and they needed to have 45 on this scale. And in fact, they have more like 60. So this was a sample of moderate to severe patients. What happens is all the conditions improve quite dramatically in the first 6 weeks, including the placebo condition. But there are two conditions, and this is the combined, and this is the Prozac only, that improve more. And actually, these two conditions are significantly better than these other two. What is surprising is that psychotherapy alone for this particular group of patients with moderate severe depression was not really better than just support with a pill placebo. Actually, the two lines are basically the same. And this was a big surprise because we were expecting that cognitive behavioral therapy would be, without medication, to be more effective. One important thing to notice here is that the means, however, at the end of treatment of 3 months, even in the most successful conditions, are above the threshold for some clinically significant depression, because below 28 means to have reached full recovery. So it means that even for highly successful treatment, the chances of having reached full remission of a condition are fairly low during the first 3 months, which basically points out that this treatment, first of all, are not terribly effective to begin with, and even when they are effective, and that depression requires a long period of treatment in order to reach remission. The same picture you get when you ask the adolescent to score depression. So the situation is basically the same. So both the clinician and the adolescent had the same understanding and the same perception of their symptoms of depression. If you quantify and you basically classify the patient into improved and not improved, you get that the combination of Prozac and cognitive behavioral therapy has a success rate of 71%, meaning 71% of the randomized to this group was about 112. The entire sample was about 400. I might have forgotten to say that was 439. So this is about 110. 71% were improved, medication only without psychotherapy 61%, and cognitive behavioral therapy 43%, and placebo 35%. These two actually were not statistically significantly different one from the other. If you want to try to quantify further the magnitude of the effect, one can use this measure that is called number needed to treat. The number needed to treat, it tells you how many patients a clinician needs to treat with a particular intervention in order to add one patient to the improved patient to the one that would improve anyway, regardless of the intervention. Of course, the more effective is the treatment, the lower is the number needed to treat. For a condition that has an inevitably negative prognosis, I don't know, what can example could give, like, let's say for a moment that pneumonia has a really negative prognosis that does not improve without treatment, and you use penicillin. With penicillin, you have 100% improvement. Without treatment, you have 0% improvement. So you have a number needed to treat of 1, because you just need to treat one patient to add 1 to those who would improve without the treatment, which are 0. For depression, it's not that effective, even though it fares fairly well with other treatment too. With combination, is 3. So if you treat 3 patients with a combination of psychotherapy and medication, you have that 2 patients will have improved regardless of treatment, and 1 will improve because of the treatment. With fluoxetine, the number is 4. So of 4 patients treated with Prozac, 3 will have improved regardless of Prozac, and 1 will have improved because of Prozac. For psychotherapy, the number is much greater, 12 patients. So you need to treat 12 patients to add 1 will not have improved without the psychotherapy. So cognitive behavioral therapy is not a very efficient way of treating depression, at least this type of moderate to severe depression. If we look at a measure of suicidality, suicidal ideation during the study, you see that at the baseline, there is some suicidality, in spite of the fact that we can rule out all the really high risk for suicide, because suicide is intrinsic in depression, and so thinking about suicide is sort of normal for depression in some way. And there is improvement, quite dramatic for all the conditions, more improvement, however, in the combined treatment, and this time in the cognitive behavioral therapy improvement. So psychotherapy seems to be particularly effective, more effective than medication for some reason, and placebo in decreasing suicidal ideation. It's something that still needs to be understood fully, but it's a very interesting finding. If we look, however, at episodes of suicidal behavior, those, what I show is basically is all the patients recorded suicidal thinking during the period of the 3 months, and this is the report. But what happens about having episodes like suicidal attempts or threats of suicide? We had a total of 21 suicide-related events, which include threats and suicide. And we have 6 of these 21, which of this category is subsumed into this one, who are actually suicidal attempts. Very small number, if you think about. So 21 out of 439 subjects. And the distribution is interesting because the 2 conditions without the medication, that were psychotherapy and placebo, had a rate of 3% or 7 events. On the contrary, the 2 conditions with the medication, the combined treatment and medication only, had a rate that was roughly twice as much, actually 14, the double. So in some way, the TADS confirm that intriguing and difficult to reconcile finding, which is not really a fluke, is really something real that was perceived and recorded in the FDA meta-analysis of all clinical trials, that for some reason that we don't understand, in spite of antidepressant being effective in treating depression, in spite of antidepressant by and large decreasing suicidal thinking, for most subjects. Still, there is, for some idiosyncratic reason that is not clear to understand, that probably relates to some subjects that are predisposed, but we don't know how, to act out during the treatment with medication. We have a higher rate, twice the rate of suicide-related behavior in the treatment with antidepressant compared with no antidepressant. I want just to conclude that the current understanding is that in adolescents, fluoxetine, which is the drug that has been better investigated, is considered an effective treatment, and so it should be considered, and actually is FDA approved for the treatment of depression in children and adolescents. So consistent with that indication, the current understanding is that clinicians should not avoid using fluoxetine and maybe also other SSRI for the treatment of adolescents with depression. However, the treatment needs to be carefully monitored because some subjects that we cannot identify a priori, unfortunately, can show irritability, restlessness, anxiety, and suicidal ideation on behavior. Because this is a risk that, even though not understood yet, appears to be linked with the use of antidepressant. So in conclusion, I don't think I have clarify what is myth and what is reality. There are concerns, and there are data that I think help quite a bit in understanding that antidepressants, when used properly, are an effective treatment. But for some reason, there are some risks related to that, and that's why it's very important for clinicians to monitor and not to dispense the drug without appropriate follow-up. I'll be glad to answer questions, and I will stop here. Thank you. Yes, please, if you have questions.
I was just wondering, since the research has found that with antidepressants it increases suicidal behavior among adolescents, I was wondering if it's been shown to show more suicidality in adolescents than with adults.
The question is that suicidality has been found to be linked with the use of antidepressant among adolescents, but what about adults? And the answer to that is that the FDA is currently looking at the database for adults, and then also a number of people are doing that exactly. About 10 years ago, there was that concern that was raised in the early 90s, and at that time, an analysis conducted on available data didn't show that actually the use of Prozac, because Prozac was primarily the drug on the market at that time, was increasing the risk for suicidal behavior among adults. But since then, we have much more data available that have been accumulated in these past 12 years, and many more drugs like Prozac has been introduced into the market, so it's time to look at this issue again. It's a very obvious question, and hopefully in a few months there may be some answer to that effect.
Ben, just to augment that a little bit, you said this, but I think it's worthwhile repeating for the audience. Those of us who have gray hair and trained long ago were taught widely at that point in time. Textbooks 30 and 40 years ago, and even up until 20 and 25 years ago, strongly emphasized that a time to monitor was soon after you started antidepressants. And it was fairly routine, and it was conveyed in residency. At this time, there were no SSRIs. And I think that's relevant for the clinicians and those who prescribe to just pay attention to, because this is an antidepressant phenomenon more than likely. The data, I think, frankly should and will be updated for the current medications, but what really counts is that, and you've said this nicely, is that the data shout at you that says that the worst risk of all is to not treat. That's what actually induces most suicidality, because it's associated with the real underlying depression. And the rates go down with treatment, but the caveat that must go along with it is that clinicians and family members need to be cautioned that this is a time period until one gets well, that you need to be very observant and careful.
My question actually was along those lines. Is there data that tells us what the window of highest risk is and when that window seems to end, where the close monitoring can be relaxed?
It hasn't been incontrovertibly shown experimentally, but I think all the data seems to, and TadsTED is consistent with the fact that these events tend to occur in the first 4-6 weeks of treatment. All the suicidal attempts, almost all the adverse suicidal attempts in TADS occurred quite early in treatment. So really the period to pay attention are the first 6 weeks, particularly the first 4 weeks, actually. Yeah.
In your blind studies and trials, was there ever a point where you were able to link violent acting out behavior with personal suicidal tendencies in order to get some sort of a predictive forecast of a potential larger problem than just a individual destructiveness?
Your question is if there was any signs that were sort of predictive of destructive behavior? Anecdotally, yes, but it's very difficult experimentally to find a signal. You know what it is? I mean, each case, of course, a single case has their own history that is revealing and is suggestive of a number of explanations within a clinical trial, because a clinical trial is an experiment, but is also is the composite of all the different single stories of a patient that participate into that. So I can certainly relate a number of possible stories that are suggestive in that way, as a number of clinicians probably in this audience have their own experience. But if we want to talk about experimental data, I don't think that there is really a clear link of a sign that indicates that the patient. I mean, folklore basically say that irritability, if a patient has a negative behavioral activations, starting a medication, doesn't sleep well, feel nauseous, feel restless, had akathisia, the same inability to stay still, that's certainly not a very good thing, particularly if he has an increased anxiety and sometimes panic attacks. You have seen that, and most clinicians will probably stop the medication at that point and try something different. It's plausible that a number of these adolescents, in the meantime, had an availability of a means to commit suicide, and they did. And that's why we have anecdotal reports of committed suicide during the use of SSRI. Yes.
Psychiatrists are not going into child and adolescent psychiatry. I'm just curious as to why psychiatrists are not picking that field as a field because of such importance today. And this has been another journal, U.S. News, World Report, and so forth, that we need more child and adolescent psychiatrists, but so few. Pick that as a
Yeah, the question is why there are so few child and adolescent psychiatry in the United States. Good question. It's common to a lot of other countries. like Canada or UK, Australia, New Zealand. So I don't think there is any country that has an abundance of child psychiatry for some reason. It's a subspecialty in most countries, even though in some European countries it's a specialty of its own, but doesn't seem to be maybe more successful. I don't know. People have been speculating about that, particularly the Academy of Child and Adolescent Psychiatry periodically has working groups to try to identify if that's why it's the case. I don't know, I just think it's a long way. You know, you need to go through medical school, you need to go through psychiatry, and then to elect subtraining in child psychiatry. Certainly the fact that mental health has been reimbursed less than other part of medicine has not helped. The fact that probably a third of children and adolescents in this country are covered by Medicaid or they're uninsured. Certainly also that doesn't help. And so the child psychiatry are few, and they're also distributed in the wealthiest county of the United States. And so, for instance, where I live in Montgomery County, in Bethesda, there is a fairly high concentration of child psychiatry, and then in some rural area, probably are none. It's a big problem.
Donna, just before you do something, because I would like to thank Dr. Vitiello. I mean, he's actually summarized a very difficult topic. I would like to also, in recognition for the theme for this conference, it is stigma, and it's doing it through knowledge and understanding, point out that this is really the only good solid study, this TadsTED study that's out there right now. And I think people, I mean, real solid ones of an adequate sample size, good controls, multiple sites, and really looking at the parameters. And for those in the audience, I would encourage you to become voices. The media really did, I think, simplify this and did a disservice in the process. It became the association with those early things and missed the whole story. The second piece of that frankly disturbs me a lot is that for those who need it, you can face the data now. Tom Schwenk and David Rosen and others who are good primary care physicians and interested in depression have pointed out that in primary care settings, the prescription rate for giving antidepressants to adolescents who are depressed has dropped in various settings from 10 to 30%. It means that at this stage people are responding to things. One of the concerns that's been expressed is malpractice, liabilities, etc. And all of the people here need to become voices for saying, let the data drive these decisions, not the hype. So thank you for addressing a very difficult subject.
Thank you.
Thank you very much.